Good afternoon, everybody. Thank you for coming to this session. So this session's been organised by the Society of Back Pain Research, and we're delighted to have two excellent speakers this afternoon. The first speaker is Gail Sheridan, and Gail is Head of Pain at Connect Health and a consultant physiotherapist and an honorary research fellow at Keele University. So we're going to have that talk first, and then a second talk presented by Whitney Scott, and then we're going to take questions after both presentations. So if you can make a note of any questions you've got for Gail in this session. So thank you very much, Gail. Thank you.
Good afternoon, and thank you, Barry, for the introduction and for the organisers for inviting me to speak today. So the title of my presentation is Your Patient Isn't Suitable for Surgery, What Now? Tamar Pincus and colleagues published some papers where they looked at the challenge of spinal orthopaedic services, and of course this also applies to neurosurgery services. And you know, these services have significant challenges, and they do see patients, of course, where surgery is either not indicated or more surgery is not indicated. And these are some of the most challenging and complex patients. Usually they've had pain for a long time, and the pain is having a significant impact on their life to the point where they're considering a surgical opinion. And they often are at the end of the medical solution journey. And of course, when patients are told that perhaps surgery isn't the answer for them or the way forward for them, it's understandable that they may become upset or angry. And while some patients are referred on to other services, many are discharged because they have exhausted the other options. And the title of this paper really sums this up: Taking Patients to the Ice Cream Shop, but telling them that they cannot have ice cream. And when we think about the problem of pain itself, obviously the adverse impact of pain is a problem. But as human beings, we also have very normal, understandable reactions to pain or responses, and these can be cognitive or emotional and behavioural. And sometimes these are helpful and adaptive, but other times they can be unhelpful or inflexible or maladaptive. And of course, that all depends on the context. And the term, the normal psychology of pain, has been coined. And Whitney Scott, our next speaker, and Lance McCracken have usually defined two types of suffering in relation to this. So primary suffering is in relation to the physical pain itself, and secondary suffering is the hurtful or ineffective responses to pain. And if we just think very briefly about two common behavioural strategies that patients might try, we can see that in the short term, these might be helpful, and in fact that reinforces the behaviour, but they might also be unhelpful in the short and particularly the long term. And so when working with patients in pain services, often we're trying to raise their awareness of how they're responding to pain and explore the workability of that in both the short term, but crucially in the long term as well. So if you take the example of someone taking medication or alcohol to excess, it may indeed reduce their pain in the short term, but of course they may experience side effects and complications and interactions. And over time, if they have persistent pain, by definition, their pain persists, albeit it might vary. They might also then expose themselves to risk of addiction, dependence or tolerance. And of course, we know that both medication to excess, particularly perhaps opioids, gabapentinoids, and alcohol to excess, will also impact physical and psychological functioning, can affect people's ability to work, their relationships, as well as their health. If we take the example of someone avoiding activities that they anticipate might increase their pain, again, very understandable response. And by not doing those activities in their mind, it might well keep them away from that extra pain associated with the activity. But of course, they're likely to engage in less rewarding, meaningful mastery activities. And over time, pain is likely to remain but vary. And in fact, most of the patients I see tell me that their pain gets worse over time. So it isn't a helpful long-term strategy in terms of reducing pain, and of course they tend to do less of the things that are important or meaningful to them in life, and as a side effect of that, obviously mental health and mood and things can deteriorate, and quality of life overall is poorer. So of course, as clinicians, what we want to try and do is identify if pain reduction has been tried, and if not, we should optimise that. But by the time people come through to surgical services and pain services, they have had their pain a long time. They've usually spent a lot of time and money on alternative and complementary treatments. They may have tried a lot of gadgets and gizmos and aids and adaptations, and they're seeing a lot of clinicians. And despite their and everybody else's best efforts, these things have not got them where they want to be in the long term. So they still have pain to the point where they're consulting because of it. They also are likely to still have significant impact in terms of physical and psychological functioning and quality of life. And these things also come at significant cost, not just financial cost, but cost in terms of time and energy and effort and emotion, side effects, complications and interactions. People get their hope up that the next clinician or the next treatment is going to be the answer, and then they experience a serial demoralisation when it doesn't produce the benefits they'd hoped for. So these things aren't working in the long term. In fact, over time, physical and mental health is deteriorating, quality of life is deteriorating, pain remains, but they now have a lot of additional secondary suffering. And of course, if we want to help our patients have a different experience way forward, then we need to do different to get different. And I guess by and large, that's around trying to help them to respond in more flexible, adaptive ways to their pain, such that these things don't needlessly limit living and they can live a life adequate to their needs. So really trying to reduce that secondary suffering and help people to have full, free, vital, meaningful lives with pain. So what can and what do we all perhaps try and do? Well, of course, it's very understandable that people can be distressed. I certainly see a lot of distressed patients in my pain service. I don't always give them the answer or the solution that they come expecting. And it's easy for all of us to get drawn into the trap of suggesting perhaps slightly more spurious or tentative other treatments or referrals, where perhaps we might be better sitting with that distress, giving them time and space, naming it where that would be helpful, and validating that their experience is reasonable or their response and distress is reasonable given their experiences. And if possible, it can be helpful to try and differentiate between pre-morbid or pre-existing mental ill health or distress and that's secondary to pain. So, that related to bereavement or trauma versus because of the impact that pain's having on someone's day-to-day life. And that's because what can help can be different. So whilst pain services, for example, can help both types of distress, some patients may have their needs better met in mental health services, particularly those with primary mental ill health. And of course, we're all looking out for patients who are actively suicidal and need to help them get timely and appropriate assessment and help. And I guess this can feel like quite a hopeless message in that, you have perhaps come to the end of the line in terms of treatments that are likely to reduce your pain, at least in a reliable or sustainable way. But actually it can be quite a hopeful message that there is a different way forward here. And that's about helping people to get control of their life direction with pain, not necessarily control of pain. The literature on reassurance is quite interesting. So there's a quote that talks about reassurance being one of the most commonly used, poorly understood and least effective approaches that we have as clinicians. And the literature also suggests that as clinicians we become deluded perhaps a little bit into thinking it's more effective than it is. Because in the consultation or in the short term, patients might appear reassured, but in the longer term they perhaps are not, and the literature supports that. So again, Tamar Pinkers and colleagues looked at, if we are going to do reassurance, we obviously want to do it as effectively as we can, and how might we do that? And they looked at some orthopaedic spinal services and did some qualitative research. And they identified that there are some specific behaviours that are required from practitioners in order for patients to feel reassured to then commit to self-management. And in the absence of these behaviours, patients often feel dismissed, disbelieved. They reject the advice to self-manage. They report distress and anger and the intention to reconsult. So the 4 themes they identified was knowing my whole story. And that's very much about, as a clinician, communicating to the patient that you have read their notes, you've done appropriate investigations and physical examinations, you've understood their medical journey to date and their lifestyle and their worries and concerns. So you know them. Seeing the right person is about building trust and empathy, showing compassion, but it's also about coming across as someone who's credible, that has the appropriate qualifications and experience to be able to help them. Nothing to worry about is moving away from generic reassurance and generic explanations for pain to really make sure that we individualise those to the human being that's suffering and sitting in front of us. And getting to grips with my problem is about providing a clear a message about the patient's condition and a clear management plan and way forwards for them. This quote here talks about the effectiveness of reassurance depending mainly on the quality of the relationship rather than the words actually spoken. And that reassurance tends to be far more effective if it is individualised and the patient can say, "You're talking about me." And crucially also, if it links psychological and social factors with the biological. So we might, as well as trying to reassure patients, and as part of that indeed, we might try and make sure that they have a more contemporary evidence-based understanding of their pain. And so we might want to try and help them to reconceptualise their pain. And this is based on the idea that pain is not an input but an output. It's a multiple system output activated by the brain when it perceives that threat or danger to the body tissue exists. And of course, as an organism, our brain all the time is looking out for threat. It's a threat detection system, if you like, and it's looking out for both internal and external threats. And that's really important to our survival as an organism. But it also helps understand how people can have pain and have little, no, or a lot of nociception. So it helps us understand that variable relationship between tissue state and pain experience. This is one of Laura Mosley's model, and it just builds on this a little bit. So this idea that the brain all the time is asking, how dangerous is this really? And it's very much involved in sense-making of its experiences. Because that's really important. We need to know, is it a cat or is it a lion that's in front of us, so that we take the appropriate response. And the outputs, depending, the answer to the question, how dangerous is this, determines those outputs. And there may be motor outputs, so action outputs, immune outputs, sympathetic and parasympathetic outputs, but also pain may be the output. And there's many factors that contribute to the answer to the question, how dangerous is this really? So of course there may be some nociception, there may be other pain processes like central sensitization, there will be cognitions, emotions, previous learning and experience, and all these things together the brain makes sense of, and that determines the output. So these things determine whether and to what extent someone experiences pain. And all the guidelines, of course, suggest that for most people, we need to try and help them to self-manage. But there are different models of self-management. And I guess I'm talking here about the model of self-management where people are empowered to have the knowledge and skills to manage their condition, but also to know when to seek appropriate healthcare. So it's not a disposal, go away and never darken our door again self-management approach. It's about an appropriate relationship with healthcare providers. And if you're looking for somewhere where there's some good quality resources to help patients reconceptualise their pain and to help initiate or support them on the journey towards self-management, then you could look at the Flippin Pain website. And just to disclose an interest here, I'm part of the Flippin Pain group. So Flippin Pain is actually a public health campaign. It's aimed at the public, it's aimed at people with lived experience and their loved ones, and it's also aimed at healthcare professionals. And it really tries to help flip, i.e. turning on its head, people's understanding of pain. It tries to help them to make wise healthcare choices and also to help support them on that initial journey towards more effective self-management. And there are a number of key themes to Flippin Pain. So the first one is that persistent pain is common and can affect anyone of any background. Hurt does not always or necessarily mean harm. Everything matters when it comes to pain. So your worries, your concerns, your previous experiences, all of these things, context is very important. That medicines and surgeries are often not the answer. That understanding pain, at least for some people, can be key, and that recovery is possible. Here, recovery doesn't necessarily mean a significant reduction in pain. So recovery could, for some people, mean having better quality of life and functioning with pain. On the website, there's some curated resources, so ones that people can watch or listen or read. There's ones about understanding pain, ones about self-management, and there's also some aimed at healthcare professionals. And so these are from all over the world. There's some links to various resources there. We've also worked with experts in the field to develop some Flippin Pain bespoke resources. So we've worked with people with lived experience, with Loma Mosley, with Cormac Ryan, and with Tasha Stanton's group in the US. And we're continuing to add to this. So we're working with a group in America around about flipping osteoarthritis. We also have something affectionately called the brain bus, although it's a little bit more like a van, and it goes out and about, and it creates an opportunity for members of the public to come and engage with interactive experiments, again aimed at trying to just help undermine a little bit their fixed ideas about pain and try and start that reconceptualization journey. And we also have a lot of recordings of seminars on the website, and we do webinars and face-to-face seminars. And we also raise money for charity Pain Concern at the moment. We have a week-long cycling peloton, along with lots of seminars and the brain bus coming up shortly. Of course, where you have it available to you, services, you might want to refer to therapy services or perhaps to a pain service. And whilst pain services referral criteria do differ, they tend to have quite a few in common. So typically it would be pain that's lasted longer than 3 months, where pain is either no obvious cause for the pain after appropriate investigations, or the cause has been identified but no specific treatment can be offered or is acceptable, and where pain persists despite appropriate treatment. Very commonly, one of the referral criteria is that patients should have completed all pain-related consultations, investigations and treatments elsewhere prior to referral to a pain service. So oftentimes we're not so successful at reducing pain in a pain service. It's a bit of a dirty secret in a way. Most people have tried all the treatments we have available by the time they come to us. Of course, sometimes we can, and where we can, we try. But we tend to be much more successful at helping people to have full, free, vital, meaningful living with pain than we are at significantly reducing pain. And what isn't helpful if we're trying to help people on a journey of acceptance and focusing their and our energies on living well with pain is at the same time they're being offered investigations and treatments aimed at reducing their pain. So we do prefer that those things have been completed, all investigation results fed back and actioned before patients are referred to pain services. And of course, there are many people who have persistent pain who don't need to come to a pain service. They're functioning reasonably well. So generally, we tend to only see the patients where pain is having a significant impact on day-to-day functioning and causing distress. And if you're not aware, the British Pain Society have recently updated their pain management programme, evidence-based guidelines. They were reissued a few weeks ago. So this is my final slide, just to kind of pull this together a little bit. And I guess what's crucial for all of us, wherever we work, is that there's concordance across the care pathway. So all of us could perhaps do more to prepare patients for a consultation regarding a surgical opinion, to help align patients' expectations, and perhaps do a better job at addressing the needs of patients when surgery is not recommended. So they're not discharged with nowhere to go and nothing, and perhaps just left and feeling abandoned. Surgical services, obviously trying to ensure that there's effective individualised communication, so things like building trust and rapport, demonstrating empathy, and integrating psychosocial factors into their assessment and management. And if surgery is not the answer, then surgical services are the most credible people to be giving that message, but to giving it clearly, both verbally and in writing. And not to judge the success of a consultation based on whether the patient is distressed or not. It's okay to be distressed. Consider giving a hopeful outlook that there's a way forward that doesn't necessarily involve surgery or injections or medication. Consider initiating, signposting or referring for support around pain reconceptualization if that would be helpful, and around supported self-management. and of course referral to pain services, but trying to help again manage patients' expectations that pain services can't necessarily reduce their pain. Thank you.
Thank you very much, Gail, for a great presentation. So I would like to introduce to you our second speaker. Dr. Whitney Scott is a senior lecturer in clinical health psychology and a clinical psychologist and research lead at the Input Pain Management Unit at Guy's St. Thomas Hospital. She has many research interests in psychological treatment, including acceptance and commitment therapy for chronic pain management. Her research has explored online delivery of ACT and chronic pain management in specific populations, including people living with HIV. She has over 75 publications, and I'm really looking forward to your presentation.
Thanks so much, Jerry, and for everyone being here today. I'm thrilled to be part of this session, which very much builds on Gail's excellent talk, looking at sort of a different way of supporting people living with persistent pain. So I'll specifically focus on recent advancements in one type of psychological therapy called acceptance and commitment therapy, or ACT, for persistent pain. So Gail really nicely set this up, but we need to be thinking about all pain in terms of a biopsychosocial model. So we know that pain is not just a physical experience in the body. Its components also include cognitive, emotional, and behavioral aspects, and all of this, of course, has to be understood within the person's social context. So as was really nicely discussed, we know that people's appraisals of the threat value of pain, levels of anxiety and depression, as well as their social support, can have a major impact on how disabled and how distressed someone is with pain. And there's now a well-established body of evidence that some of these psychosocial factors actually predict pain-related disability and distress to a greater amount of variance beyond the level of pain intensity itself. So really building on this evidence of the role of psychosocial factors, there's now a large body of evidence looking at cognitive behavioral therapies that target these aspects of the pain experience. So traditional cognitive behavioral therapy, or CBT for short, is the most established psychological treatment as applied to chronic pain. So there's now at least 59 randomized controlled trials as of the last Cochrane review of psychological therapies for pain. And generally speaking, these samples are comprised of people with low back pain or kind of widespread musculoskeletal pain, or in fact, they're mixed chronic pain samples with a range of etiologies. But what we see looking at CBT relative to either active or inactive controls, generally speaking, there are small to moderate effect size improvements in key outcomes like pain-related disability and distress. And I should say, and kind of Gail already hit at this, our psychological approaches like CBT tend to have bigger impacts on outcomes like disability and distress compared to pain intensity. So I'm particularly interested in ACT as a more recent form of CBT, which I think has a number of advantages in terms of its kind of underpinning theoretical model. So the model underpinning ACT is the psychological flexibility model, and this is really a broad model of the behavioral processes that underpin human functioning, both in the context of living with pain, but also in the context of just being a human trying to navigate the challenges of living in this world. So psychological flexibility, just in brief, describes the capacity to persist with or change behavior in a manner that incorporates conscious and open contact, really in a moment-by-moment way, with experiences like bodily sensations and thoughts and feelings related to pain or other experiences, and in a way that really serves one's goals and values. So within this model, we kind of think about these three processes that we call sort of acting with openness, awareness, and engagement. And as applied to persistent pain, again, this could be any kind of pain condition, the kind of model assumes that, or proposes that psychological flexibility is this sort of key mediating process between the experience of pain and pain-related functioning and quality of life. So within this model, the concept of pain acceptance, very much linked to what Gail was saying, describes stopping of ineffective efforts to control pain. So it's not saying that people always have to experience pain. If there is an effective pain control strategy that doesn't come at significant costs to a person in their life, that may be workable, as we say. But it's those instances where a person's pain control strategies not only don't work to relieve the pain, but also have these significant costs for their functioning and quality of life, that we think about maybe a different approach. So letting go of that struggle to control pain, coupled with a willingness to experience pain in the service of being able to engage more fully with what a person cares about in their life. So ACT as a treatment approach primarily targets this overarching process of psychological flexibility with a view of improving functioning and quality of life in the presence of pain. So it's not focused on reducing or controlling pain. So ACT uses a number of strategies to enhance this process of psychological flexibility. So we use strategies like metaphors and experiential exercises, and this is really to help people to come into contact with experiences that they struggle with or otherwise avoid, and to take a different perspective on these experiences so that they can then make perhaps different or more helpful choices to enable them to have that fuller quality of life alongside pain. We also very much draw on mindfulness or kind of present moment awareness exercises, again, to enhance this capacity to notice what's showing up for a person moment by moment flexibly and focus more on the present moment when that might be helpful. And that can also be a vehicle through which people can better come into contact with what they care about in life. And then we have a number of tools and strategies through which we can help people contact and clarify what they do actually care about in life, and then to take steps towards those values and goals in the presence of pain. So as a newer form of CBT, ACT has a growing but less established evidence base than traditional CBT. As we can see from this non-systematic review here, as of 2020, there are at least 25 randomized control trials of ACT relative to some active or inactive control condition. And certainly there are kind of improvements methodologically that could be made in the conduct of some of these trials, but there is, as I said, a growing evidence base for ACT. And what these review authors concluded was that there was evidence suggesting that there were meaningful improvements in pain interference and disability, depression, and quality of life for people that received ACT relative to some control condition. It is important to highlight that the current state of the evidence is that effectively ACT and traditional CBT produce comparable outcomes. So we can't say that one is better than the other, which is kind of generally what we tend to find for psychological treatments in the kind of broader field. And it may be that both are suitable treatment options for people living with pain. That said, both with traditional CBT and ACT, generally, even though there are meaningful improvements that we do see, our effects do tend to be modest, as is often the case with our treatments for pain. So the kind of work that needs to happen now is to focus on how can we improve our impacts with these approaches to treatment. And a couple of avenues that are worth pursuing include, one, looking at how we can better select people for these treatment approaches, so optimizing who's offered such treatment. And then two, better understanding the processes of change underlying these treatment approaches so that we can then better understand how to target those processes of change. So I'll focus on both of these issues in the rest of my talk, or later in my talk. So moving on from randomized control trial data, I'll talk a little bit about some observational cohort, sort of real-world data from the pain service where I'm based clinically. So that's the input pain unit at St. Thomas's Hospital in London, and it's a specialty care pain service. So our service offers a number of sort of intensive and less intensive ACT-based treatments that are delivered across our multidisciplinary team. So that team includes psychologists, physiotherapists, nurses, and occupational therapists who all apply this ACT-based treatment model. And we have one particular pathway within our service that's for patients that have been deemed medically suitable for spinal cord stimulation. And prior to sort of moving along that pathway for the trial spinal cord stimulator, they engage in an intensive 2-week ACT-based, effectively rehabilitation program. And really the focus of this program is to sort of set them up to be in a better position to benefit from ultimate kind of spinal cord stimulation, using some of these ACT-based principles so that they can improve their quality of life and functioning while they're waiting for this kind of medical intervention. So the data from this study here, they are a bit old. I'll present some more recent data on the next slide. These data are from 2012-2013 with 86 participants on this neuromodulation pathway. And just over half of them had spinal pain with neuropathic features. So these participants completed pre- and post-treatment self-report questionnaires looking at sort of key pain outcomes of functioning and depression symptoms, pain intensity, and then our kind of key treatment process variable of pain acceptance. So this was just a very simple pre-post treatment study. There wasn't a control group. But what we did see was that there were kind of moderate effect size improvements on the functioning and mood outcomes, as well as, that's strange. Here we go. As well as for pain intensity. And we did observe a small effect size improvement on pain acceptance, and all of these were statistically significant. Just interestingly, we also looked at kind of the onward pathway for these patients, and the majority of them did go on after the program to receive a trial stimulator, and then the majority of those who had the trial that was successful went on to the full implant. Of the minority that didn't go on to receive the trial after our program, those tended to have higher levels of depression and lower pain acceptance relative to those that did go on for the trial. So that was sort of an interesting finding. So we've continued to run that program for a number of years up until just before the pandemic. So the data for the 2 years before the pandemic, again, an intensive residential pre-neuromodulation program are on the left there, and we see kind of roughly comparable outcomes to the data I presented that were from the older cohort, kind of small to medium effect size improvements in things like functioning and depression. We kind of reworked this program after the pandemic for virtual delivery for obvious kind of reasons, and we did see some improvements, generally small in some of the outcomes still within this virtual format. But generally speaking, the outcomes in this virtual format were smaller than kind of our original residential program, which perhaps isn't surprising, or is not unsurprising. So what we can kind of say here is that even, and with the caveat that this is, again, an uncontrolled study, that even in the presence of kind of waiting for a medical treatment to hopefully relieve pain, people could still develop pain acceptance and draw on those strategies so that they could live well and fuller and have a better quality of life in the presence of pain. So it's somewhat of a contradictory kind of scenario, but people were still able to improve their functioning in this situation. So I said earlier on that I think one of the key strategies for improving our outcomes with respect to ACT-based treatments or kind of cognitive behavioral treatments for pain is important to better identify and select people who are most likely to benefit from these treatment approaches. So my colleagues Helen Gilpin and Lance McCracken have done some work in this area to try and identify predictors of ACT treatment responses. So they started with a systematic review looking at what they termed contextual cognitive behavioral therapies for pain. So that basically refers to ACT-based treatments or mindfulness-based treatments as well. So they identified 20 studies and looked at a range of predictors, including demographics, pain intensity, and psychological variables, including things like baseline psychological distress. And it was somewhat disappointing in that they really didn't find any consistent predictors of treatment response. So one of the issues is that there was only a few studies investigating each of the predictors, and there were kind of inconsistencies across those studies. So there wasn't kind of a good body of evidence for any one kind of individual predictor. They then built on that review by looking within some of the data from our input pain service again. This time it wasn't specific to the spinal cord stimulation pathway. These data come from the more kind of general pain management program that we offer for people with mixed pain conditions. And this study was in a sample of 600 or so patients presenting for our intensive residential program. And again, it was a pre- and post-treatment design, and they were looking at what baseline predictors, if any, were there of treatment responses in the context of this program. So again, they looked at things like patient demographics and pain intensity, as well as psychological distress at the start of treatment. And one of the things that they argued or sort of concluded from their systematic review was that basically most of the studies to date, even though they were based on ACT, which has sort of a foundational theoretical model, they weren't actually selecting theoretically derived or based predictors of treatment. So they weren't looking at facets of psychological flexibility as predictors of treatment. So for this study, they then did select theoretically based predictors, including elements of psychological flexibility that tapped into the kind of open, aware, and engaged behavior processes. So what they found, there was some evidence for baseline psychological distress, so lower levels of psychological distress predicting better functioning or better changes in functioning over the course of treatment for some of the outcomes. And they also found that one of the measures tapping that awareness feature of psychological flexibility, that did predict some of the functioning outcomes. But across these two predictors, there were inconsistencies across outcomes, and largely speaking, the variance accounted for was small. So they concluded that it still may be worthwhile to approach kind of the investigation of treatment predictors from this theoretically consistent way, but more research is needed. And one thing to highlight from their study is that they looked at individual predictors at baseline. So looking at sort of regression models where individual predictors, whether that's demographics or pain intensity or distress, looking at sort of entering them all into the model and seeing the unique variance accounted for by each of those predictors. So we then built on this by thinking about what if it's not individual predictors that is important, but rather the profiles or the mix of levels of different factors of psychological flexibility that might influence treatment response. So this is again another observational cohort study, pre and post design, with our input pain clinic kind of population or a sample of that population with mixed pain conditions. And these data come from an entirely separate sample to the study that I presented previously. So this time it was 415 participants, and they completed psychological flexibility process measures, again, tapping into facets of awareness, openness, and engagement, and then our key pain outcomes, looking at things like pain-related interference, depression symptoms, and pain intensity. So what we did here was with the baseline data, so cross-sectionally, we conducted latent profile analyses to see whether there were meaningful subgroups based on these psychological flexibility process measures. And we found effectively 3 subgroups. So in the first subgroup were people that scored low across all levels of those measures of psychological flexibility. In the middle, it was people with kind of low scores on pain acceptance and then moderate scores on awareness and committed action, reflecting kind of that engaged quality of behavior. And then in the third profile, people scoring sort of moderately on pain acceptance and then high on the other 2 psychological flexibility processes. And what we see is that in the baseline sort of pre-treatment data, these groups differed in meaningful ways with respect to scores on pain outcomes. So people with the lowest levels of psychological flexibility had the worst pain outcomes. So they had higher levels of interference and depression relative to the other 2 groups. And then the other groups differed in ways that we would expect. So those with the highest levels of psychological flexibility had the best pain outcomes, so the lowest interference and the lowest levels of depression, for example. We then wanted to compare whether these baseline profiles differed in terms of their changes over treatment in the key outcomes that I've talked about. And unfortunately, we found no difference in treatment change across these different profiles. However, we did do a secondary exploratory analysis where we then looked at the proportion of meaningful change across these profiles relative to meaningful change on the outcomes for the whole sample. And there was some indication that when we looked at those with the lowest level of psychological flexibility at the start of treatment, they did appear to have the greatest proportion of meaningful change across outcomes like pain interference and depression compared to the whole sample. So if you just looked at everyone together. So these data suggest that there may be something to this sort of profiling approach, although again, kind of more research is needed to see if this replicates and to better understand what profiles might predict treatment response. So I'll just finish up by talking about a particular methodology that I think has a lot of promise for helping us to better understand who's likely to benefit from these type of treatment approaches, as well as what might be the processes of change. And this is actually from a study conducted by a former PhD student, Claudia Casari, in women with vulvodynia. So that might not seem immediately relevant to this kind of conference today, but I do think this methodology, as I'll discuss, is relevant for kind of chronic pain conditions more broadly, as well as a whole range of treatment approaches for chronic pain. So I'm presenting it here to kind of highlight this as something that I think will kind of show advancements in our understanding of how people with pain improve. So certainly group level designs such as randomized controlled trials, they have a lot of promise, and they're certainly the gold standard for helping us to understand what treatments work for groups of people on average. However, they actually tell us very little about what treatments work for a particular individual. So idiographic approaches such as single case experimental designs really can help us better understand what works for individuals in front of us. And they do this through having the individual serve as their own control and intensive assessment and kind of measurement of them over various phases. So in the simplest design is an individual has a no treatment baseline phase where they undergo repeated assessment, and that's followed by some sort of treatment phase, again, during which they have repeated assessment. And this level of intensive assessment across these phases allows us to better understand how this individual is responding or not to a given treatment. So in this particular instance, this was a quite simple multiple baseline single case experimental design with 7 women. It consisted of a baseline no treatment assessment phase in which the women were randomized to different baseline lengths from 7 to 21 days. And then after that period, they all received an ACT-based treatment for vulvodynia that was delivered online. And we had sort of two different approaches to assessment. So in the first, participants completed standardized full-length assessments of pain outcomes, and given the sample here, sexual functioning outcomes, as well as the treatment process variables. And these full-length assessments were completed at the beginning and end of the baseline phase, and then again at the end of the treatment phase. And then alongside this, there was completion of daily diaries of items that reflected these outcomes and process variables. And that lasted right from the start of the baseline period all the way through to the end of the treatment period. So you can see that there's an intensive level of assessment happening throughout this, so lots of data being generated. So we analyzed these data both with visual inspection of some plots, and I'll show some examples in a moment, as well as with computing something called tau, and that effectively is a rank correlation that looks at the association between these daily diary assessments and the phase, whether that was the baseline or the treatment phase. So even with 7 participants across that range of outcomes and process variables and the daily diary and the full-length data, you can imagine that that generated a lot of data and a lot of effect estimates. So certainly I can't walk you through all of those data here, but just to say I've kind of selected out 3 of these plots for 3 participants for just the pain interference variable. And we can already see that perhaps unsurprisingly that treatment responses were highly individual. And what we did see across various analyses was that all of the women improved on at least one pain or sexual outcome, but different women improved on different outcomes, although no one improved on depression. A similar story was seen for the treatment processes of psychological flexibility, where most of these processes showed some improvement, but different women improved on different treatment processes, and this was only in a minority of participants. So these data really show us that, when we aggregate data, when we sort of collapse data at the group level, we may miss a lot of these nuances in how people are responding to different or on different treatment outcomes and different process variables. And this really kind of encourages ongoing use of this more intensive longitudinal assessment to help us better understand in a more fine-grained way what might be happening for each individual. So kind of bringing this all together, hopefully I've demonstrated that psychological flexibility is a useful model in the context of persistent pain across a range of pain conditions, including spinal pain conditions. There's growing evidence supporting the utility of ACT as a promising approach for people living with pain, and now the task is to figure out how we can improve our impacts achieved with ACT through better identifying who might benefit, as well as better identifying or better understanding and targeting key treatment processes, and more personalized approaches to evaluating treatments and investigating treatments, such as profiling or subgrouping approaches, as well as single-case experimental designs, may help us advance this work. Thank you very much for listening, and I'm happy to take any questions.
Thank you, Whitney. If you have any questions, could you please come to one of the two microphones? Steve.
Thank you both for such great presentations. I've really struggled with understanding the psychological flexibility. I need some help with, is it a kind of predictor of you getting chronic pain? And then when you've got chronic pain, you want to induce psychological flexibility, but the very people who have got the pain seem to have the lowest psychological flexibility. And I get kind of stuck in this sort of loop of psychological flexibility being the thing. And relating to that, I remember reading one of Lance's papers which kind of said, look, dump catastrophizing, all this other stuff. There's a single trait here called psychological flexibility that we need to focus on. So can you help me unpick that a little bit?
Yes, certainly. It's a really great couple of questions. So I wouldn't say that psychological flexibility is a predictor of pain onset, and in fact, I'm not really aware of studies that have directly looked at that.
No,
and I think
persistence, not onset.
Even still, I mean, possibly persistence. I would say more that once a person has pain and it's persisting, that's more likely to contribute to higher levels of disability and distress than people with improved levels of psychological flexibility. So I would kind of look at it in that group that's already got persisting pain. That's where it probably becomes relevant, and it's possible that it may influence the transition to chronicity, but I'm not fully aware of studies that have kind of looked at an appropriate kind of sample for that. In terms of, so I think there's some challenges with the word catastrophizing that I think we probably as a community need to think about a bit more, and certainly there's some recent papers looking at how people with lived experience that term. I know here at Crombie is a collaborator of mine who's talked about, preferring the term pain-related worry because kind of, as Gail said, in a normal psychology of pain, a lot of these kind of interpretations of threat are really normal. So maybe this kind of worry framing is better. In terms of the links with psychological flexibility, I mean, we certainly know that pain-related worry, if we call it that, is very predictive of pain-related distress and disability. From a theoretical point of view, I think psychological flexibility has advances because it identifies kind of core behavioral patterns that might explain functioning. Whereas if we take kind of some of the more traditional cognitive behavioral models, the fear avoidance model is one cognitive behavioral model. There's a proliferation of cognitive behavioral variables outside of that model that people have identified. And then it does become this patchwork of variables that we're trying to pit variance against to say which is the most predictive. Whereas psychological flexibility, and again, this is theoretically based, more research is needed to see whether it holds out. But there's 6 processes in theory that can account for a wide range of thought content, emotional content, and behavior patterns. So it's more parsimonious from a conceptual level, but we need more work to see whether that pans out to better prediction and things like that. Did you have anything to add, Gail?
No. Great answer.
Thank you both for really interesting talks. Gail, this one's a bit more for you. With our surgical service and our surgical waits being so long, we tend to be listing patients for surgery and cautioning them that their wait is likely to be, in excess of a year, and really almost sending them back to the pain service to be managed in that interim phase while they're waiting for surgery because there's not much more we can offer at that point. But one of your exclusion criteria was patients who are kind of ongoing with other treatments or investigations. So what should we be doing with these patients?
Yeah, no, it's a great question. Of course, very much an issue at the moment with the NHS in the situation it is. So I guess there's patients are all different, aren't they? And so there is this shared decision-making conversation to be had with patients. And I guess if patients are able to engage in this kind of an approach, a self-management approach, whilst waiting for surgery, then that's great, and we can work with them. If patients are very much invested in waiting for the surgery and see no room for anything else, then obviously they're less likely to engage in treatment and do well from it. And I think there are certainly waiting list initiatives. Pain services are providing those for patients on waiting lists for surgery. And of course, sometimes there's a role for getting patients as functioning as well as they can for those surgical outcomes, for reducing complications, for recovery and so on from surgery. But I think it's very much more of a case-by-case basis around are they open to exploring a different way forward in the meantime.
Hi, thank you both again. Just to reiterate, it was two very great talks. Nafis from Slough, we just wanted to just pick that topic of this supposed psychological flexibility, and it comes on to what you've said, Gail, also about that acceptance that they need to start looking for other things, because that's part of, maybe from a surgical point of view, I'm thinking of that as being flexible in being open and aware, and to be able to engage in that. Do you see psychological flexibility as something relatively fixed in someone's character? And if it's changeable, how do we change it? How do we make them accept that they need to be thinking about other practices? And maybe that's something which both of you possibly come at it from slightly different approaches, and I'm quite pleased to hear about that.
Yeah, I mean, I guess when we're trying to support people on this journey, we're wanting just to be curious and open to exploring a different way forward. So to have some curiosity, some openness to it, having explored everything they've tried to date and where that's got them to, and that shared understanding of more of the same is not likely to get you anything different. Would you be willing and open to try a different way forward and find it for yourself? Don't believe me or anybody else. Come on a journey, be open and try it for yourself and see. And I very much think, yes, psychological flexibility is exactly what we're trying to try and influence in patients. And at that point, I'll hand over to Whitney, because I'm sure she can pick that up much better than I can.
Just on the point of whether it's kind of a fix, I mean, conceptually, certainly we say it's contextual. So it's kind of moment by moment, situation by situation. We could vary, whether we're flexible or inflexible in any one situation. I think how we measure that right now doesn't actually reflect that, but theoretically it is meant to be kind of a moment-by-moment thing that is changeable within our context and in our interactions with other people. And I think one of the nice things about the model is it also offers a model for clinicians to understand our behavior, because this is an approach that requires us to sit with uncertainty and to say, I sit here in a position of relative, knowledge and power, and I don't have the answer, and that's deeply uncomfortable for us too. And we can bring those skills of awareness and openness to our own responses so that we're not influencing the interaction in maybe an inflexible way or in an unhelpful way. So I think that's one of the benefits of thinking about it as something that applies to the people we see, but also ourselves in a non kind of fixed way, because it's a non-pathologizing kind of way of approaching that, I think.
I think also just to add that acceptance is a process. It's not a you are or you aren't accepting. People move back and forth with that. And I guess typically with patients, we tend to not use the word acceptance because it has all sorts of connotations of, roll over, give up, play dead kind of thing. So we tend to talk more about your willing to have pain if doing so is going to lead you to somewhere different from where you are now. So is it going to help you, engage in more meaningful activities and live in keeping with your values?
Can I ask another one?
Go on then, Steve.
Sorry. I remember in the NICE guidelines doing that bit when we'd done a combined psychological doodah at the end. And then what happened if that didn't work? We wrote down out of pathway. I also remember working in South London and having patients who'd been to input in the past, some years ago when I was there, and when it hadn't worked out for them. I'm just interested in what you think about pathways and what's appropriate care for people who've even done the what used to be a 6-week program at input, and how folks, often in the community settings, what the best and most safest way of supporting or managing people who've kind of done everything and the surgeons haven't got a target and they won't.
I'm happy to, yeah. Yeah, it's a really good question. It's something that we certainly grapple with, and we do, at Input, we see re-referrals for people who have completed the program, so by no means is this, the end-all, be-all, and no one, comes back. The reality is that persistent pain is a long-term condition that people may need support with at various points in their lives. Unfortunately, our healthcare system is not set up to manage that. We don't have the resources to do that in an optimal way. I do think probably shifting care from specialty services to, primary care, the community, and thinking about, again, thinking about the social context. Why are people so distressed? We see a lot of, social deprivation. If people have access to, support for other areas of their life, if there's, better, these are big questions, but if there's, better economic equality, like all of that's going to help people in the community. And I think at some point we need to have frank conversations that's where we probably need to invest our resources. Pain clinics are great. Most people can't access them, and people need kind of long-term support in the community.
And I think peer support and other things have their place too. And of course, some people come through to any treatment at a time. Sometimes when it's not the best time for them, it's not opportune. They weren't wasn't the right time or place for them. And so when we have people who are re-referred, we again do an assessment and say, what would be different if you were to come on the programme now? And sometimes there are significant differences, often in the social circumstances, ability to engage, openness to a different way forward, such that they could perhaps benefit from that approach now where they didn't before.
Last question. Yeah.
Thanks. The ice cream shop analogy is a useful one, and the whole question of patient frustration at the end of the process. But it presupposes two things. Firstly, that the surgeons who would be the final gatekeepers for surgery are not involved early in the process. And secondly, that there's been a failure of that triage process if the patient does end up seeing a surgeon, whether a failure of the triage or whether the patient bypasses the triage. But either way, does it mean that our current thoughts about how you get to see a surgeon need to be reconsidered, and surgeons ought to be involved earlier in the process?
So I think if 100% of patients coming through to surgeon end up having surgery, I guess you would be concerned about the threshold being too high, because you would ideally have some patients who are not suitable but need that surgical opinion to make that decision. Obviously, if you're having a lot of people coming through and your conversion rate is low, it's too far the other way. And of course, surgeons get involved in people with acute recent trauma, and very, very early, don't they? But yes, I guess it's about having people with the right competencies, whether that's a surgeon or somebody else, to assess people as early as possible, or when surgery is appropriate to be being considered. And I think it's always a problem of people having to wait a very, very long time, often, to be told that something isn't the way forward for them. And there's great papers. One of them is called Life is on Hold, where patients talk about, if only somebody had told me years ago this, and it's taken me years and years for someone to say, no, that surgery isn't the way forward, or this drug isn't the way forward. So I think it's about timely interventions by the person who's got the competencies to do that.
No, I don't have anything to add.
Thank you very much, everyone, for coming to this session, and thank you, Gail and Whitney, for your presentations.
Thank you.